Hello, my name is Natalie Perez-Mendez and I'm a fourth year medical student. I will be presenting a case from MMR Healthcare, a managed care internal medicine clinic in South Florida. The goal of this short presentation is to demonstrate how lung point of care ultrasound can help the outpatient primary care physician make better informed decisions. This is a case of a 72-year-old male presenting with increased shortness of breath. He suffers from chronic shortness of breath and fatigue, but he presented with increased symptoms and a weight gain of 4 pounds for the past 2 days, which worsens with exertion and when lying down. He denied chest pain, abdominal pain, or fever. He has a past medical history of type 1 diabetes, coronary artery disease, his status post mitral valve clip and a TAVR, left ventricular failure with an ejection fraction of 25 to 30%, secondary pulmonary hypertension, orthostatic hypotension, chronic kidney disease stage 4, and anemia of chronic disease. At the time of his visit, Mr. F's vital signs included a normal body temperature, heart rate of 96, blood pressure of 122/77 supine, and 110/77 sitting. He weighed 161 pounds and saturation of 98% at rest, but it dropped to 92% after light walking for about 20 seconds. In general, Mr. F is a pleasant but tired and ill-looking male that appeared older than his stated age. Thoracic auscultation revealed bilateral fine crackles at the basis and a 3/6 systolic murmur at the apex. And his current medications include bumetanide 1 mg twice daily, spironolactone 25 mg daily, clopidogrel, a statin, a beta blocker, and aspirin. Here we have his most recent lab results. His hemoglobin is low at 11.8, but it's important to note that Mr. F suffers from anemia of chronic disease and advanced renal insufficiency. This would explain his chronic fatigue, but not his acute symptom presentation. Another important piece of information to consider is his recent transthoracic echo done by his cardiologist. It revealed severely reduced LV systolic function and EN and EF of 25 to 30%. Now, before we reach for our ultrasound probes, I want to quickly go over basic thoracic anatomy. It's important to remember that the transducer will encounter bony ribs above the target lung tissue. So the goal is to place the probe in between two ribs in a given region and aim the ultrasound beams directly through the lung pleura. Now, regardless of probe location, always identify the ribs, pleura, and the pattern below showing equidistant A lines. The regions where the transducer should be placed to evaluate your patient are labeled here on the bottom left corner, 1 through 4. The presence of interstitial syndrome, the diagnosis we have at the top of our differential in our patient discussed here, is defined by 2 or more positive regions bilaterally, where a positive region is defined as the presence of 3 or more B lines between 2 rib spaces. We'll review B lines in just a moment. Here's a clip of what normal lung tissue using the Vave point of care ultrasound device should show. You can identify soft tissue, 2 ribs, and their shadows, an intact pleural line sliding with every breath, and a consistent pattern below the pleural line. Here's a clip of one region from our patient. B lines were seen bilaterally in the anterior upper lobes. Once again, At this point, we gathered our clinical data and imaging data and decided to follow the protocol eloquently discussed by Dr. Nilam Soni's textbook shown here. Mr. F presented with shortness of breath, and upon POCUS inspection, we did see lung sliding present, so this ruled out pneumothorax. We did not see any consolidations, but we did see profuse B lines, so we ruled in pulmonary edema. And these B lines were bilateral, so we concluded interstitial syndrome secondary to cardiogenic pulmonary edema was the most probable diagnosis. At this point, the physician confidently changed our patient's medications by adding metolazone 5 mg to be taken 30 minutes before his morning bumetanide dose for 2 days, then again once weekly. We plan to follow up with him in 3 days in our office, but in the meantime, he will call our nurse on call with daily blood pressure and weight values. The doctor also decided to add home oxygen use for further support, and of course, we reminded him to maintain his low sodium diet. Here I include another great approach to dyspnea, which includes IVC evaluation. However, in the setting of this particular case, we were looking just at the lungs, so we did not take into consideration our patient's IVC condition. Here are more pulmonary edema reference images provided by the POCUS Atlas on the left and Dr. Lichtenstein on the right. Both of these clearly depict the at least 3 B lines that you'll see in a patient suffering from pulmonary congestion. To conclude, I would like to cite this landmark paper that showed the massive difference between physical examination and POCUS regarding sensitivity, specificity, and likelihood ratio. It's clear that POCUS provides a way to enhance care for our patients and allows clinicians to make a much more informed decision when it comes to patients like the one in this case. Finally, I just want to go over 3 main pearls I hope you take from this video. Firstly, for B lines to be considered pathologic, at least 3 must appear in a single rib interspace. Secondly, stick with an algorithm and understand how to narrow your differential. Lastly, because of POCUS, we were able to help our patient even more and achieve the goals of the IHI quadruple aim. We reduced radiation exposure by not sending him for a chest x-ray to investigate other reasons as to why he was presenting the way he was. This allowed to lower overall healthcare costs for him and the system at large. We also reduced his COVID exposure. And finally, we decreased unnecessary antibiotic use by confidently ruling out pneumonia. This is the end of my presentation. Thank you very much for your attention.